Thank you. I want to first welcome everybody that's here in South Florida that's at this program today. What do we hear from you all? Good morning. Our sponsor, our gold sponsors were EMD, Serono, and Sandoz. Our silver sponsor was Bristol-Myers Squibb. Our bronze supporters, Memorial Healthcare System, Sanofi, and Viatris. Our community sponsors, Mallinckrodt, Alexion Pharmaceuticals, and TG Therapeutics. And our exhibit sponsors, FlowMed Infusions, Genentech, First Choice Neurology, and Novartis. And let's give them a round of applause for being here to do this program today. Thank you. Dr. Steingo, for you all to know, he's a board-certified neurologist who has practiced in Broward County for almost 40 years. It makes me feel really old now. His practice is limited to the treatment of multiple sclerosis and related disorders. In addition to his clinical practice, Dr. Steingo has been involved in many clinical trials, including the pivotal trials preceding approval of Tysabri, Gilenya, Ocrevus, and other disease-modifying therapies. He served as a member and chair of the National Multiple Sclerosis Society's Professional Advisory Committee for almost 20 years and has been the medical director, the lead medical director for MS Views and News Now for the full 15 years. Dr. Steingo, come on up.
Good morning, everyone. Thank you for coming. Happy Veterans Day. And I repeat what Stuart said, to thank all those who served our country and gave us the freedom to be able to do this. And thank you, Stuart, for doing this for so long and providing us with all the opportunities. So we're in the land of MS. Those of you who've been to these, I don't know if I've done 15. We've done this for about 14 or 15 years. So I've done many of these programs with Stuart. I don't know if I did every one, but I coined this term, the land of MS. So you've probably seen that before. And this is what the land of MS is now. So when someone says they have MS, it's a very complicated thing. This is everything we could talk about at a particular visit. So in the center, you see what I call the control tower. And the control tower essentially is your neurologist, whose job is to help you to the best of their ability. But the important thing about this land of MS is that this is a team. The land of MS works best when there's a team and we have shared decision-making. It's very important. And then if you look around, we pick any topic that you see and discuss it. For example, on the left-hand side, second from the top, you see the Department of Education. What is that? That's what we're doing today. So the Department of Education is what Stuart provides us with, this opportunity and bringing in a bunch of people to speak to you and all the programs he does during the year. And so we have entered the Department of Education. On the top right, you see the management of MS, talking about relapses and what drugs we use for MS. The disease-modifying drugs have exploded, our ability to use that. If we were sitting here in November of 1992, you know how many disease-modifying drugs we'd have available? The answer would be 0. And now we have many of them. So that field has exploded. And then as we go down on the right-hand side, you see the symptom tower. I'm highlighting aspects of what we're going to talk about today. And why is it a tower? Because there are so many symptoms that we're able to address. And then the next category is measurement. How do we measure your progress in MS? And mostly this has been clinical. What does clinical mean? It means, how do you feel? What do you report to us? What does our examination show? And then we've had MRI scans. MRI scans we've had for about 40 years now. Big advance in managing MS. And now, exciting topic that I will talk about today, biomarkers. Are there chemical substances? We still do not have a substance, a product in the blood that can actually tell us that someone has MS. We have for some diseases, but not for MS, but we have markers now that can tell us something about the progress of the disease, and we'll talk about some of those. These topics that I'm going to talk about today are topics that Stuart selected, not me, and I'm trying to make them a little more exciting because some of these topics are topics that have been around for a long time. So for example, the first thing we're going to highlight is the different types of MS. With MS, we have spoken about the relapsing type of MS as the commonest type, that at least 90% of people start out with relapsing MS, and that there may be 10 to 15% of people who start out with a different form of MS that we've labeled progressive MS. But there is more overlap between those forms. Actually, the more we know about MS, the more we know there's some overlap. In other words, people that are relapsing early on may have some progressive tendencies, and people that have so-called primary progressive MS may also have a relapse. So there's more overlap than actually we used to understand. But the very earliest type of MS that you see on the top of the screen is called the radiologically isolated syndrome. And the radiologically isolated syndrome is where someone is coincidentally discovered to have MS. They do not have MS symptoms. They might have a headache, or they bump their head and they have a scan, and someone looks at the scan and says, your scan looks like MS. And we call it RIS, or radiologically isolated syndrome. So that may be the very beginning of MS. And we never knew what to do with it. We were uncertain. Some recent studies have been done which suggest that maybe if we have the opportunity to see someone that early, that the studies have suggested maybe we should start treatment that early. The next stage is the clinically isolated syndrome, or initial event. That would be someone's first symptom. And then moving down, we see the relapsing form of MS. And then when people had relapsing MS, we knew that sometimes they could start to progress, and we called that secondary progressive MS. I'm going to say a little more about this later. Because we split that up now, we have something we call active secondary progressive, which is a transitioning stage. When you were relapsing, but now you're starting to show some signs of progression, but you still might have a relapse. And then finally at the bottom, the progressive types of MS, including primary progressive, where someone shows a slow progression from the beginning. So this already shows you how many different types of MS. And this is the hallmark of MS, which goes back to what I said in the beginning about the control tower. MS is a very individualized disease. Everybody is very different. The way that they have symptoms is different. The way they respond to medications is different. We can't always predict outcomes. So MS is a very individualized, different disease, and everybody needs to be handled in a personalized way. I'm going to define for you here a relapse that you probably know about, but the definition is important. And a relapse means a change in neurological function, something different from before, and it could either be a completely new symptom or it can be a worsening of a prior symptom. But for a relapse to be called a relapse, it must last at least 24 hours. That means 15 minutes of numbness is not a relapse. It gives us a clue to something else. For example, in our older MS patients, if they have a loss of vision for 15 minutes, we would be worried about a stroke or a stroke warning, for example. The average age of an MS patient in the United States now is 55. 55. The MS population is aged, and the average age of a patient is 55. So we are dealing with many of our MS patients that are in older age groups where they have other medical problems, diabetes, heart disease, hypertension, and they can have other problems. So we have to be always alert to that, because the tendency oftentimes is for people to say, oh, it's the MS. We have to be alert that there could be other things going on. So in any event, the first thing is it a relapse? Has it lasted at least 24 hours? And secondly, that there should be no other explanation. For example, we need people with MS are heat sensitive. So you could have a fever. What's the commonest cause of that? UTI. Common. People may have urinary tract infections. Temperature's 102 degrees. They feel weak. They can't walk. And what do they think? They're having a relapse. And all we have to do is treat the UTI. So we need to be attentive that there's nothing else, no other explanation, or someone started a new drug that might make them dizzy. We should always think that whether there could be other factors. So is this a true relapse, or is this a pseudo-relapse? It seems to be a relapse caused by something else. And if you have a relapse, we need to think about that, because the implications of a relapse are important that we're going to go into soon. This is showing you some of the signs, early signs. So this is over here showing you some of the initial symptoms of MS. So you see over here, optic neuritis can occur in about 30% of patients. What's really interesting about this is that in people with MS, when they present with their initial symptom, even if it's not optic neuritis, and we examine their optic nerves, many times they already have some scarring in their optic nerve. So these are initial presentations, and sometimes people may have signs. It's common when someone is first diagnosed that if you go back in their history, they will have some symptoms that happened before. For example, someone might say, I had a pinched nerve. 5 years ago, my arm was numb, and they told me it was a pinched nerve. It wasn't. Or I wasn't walking well, and they told me it's my back. Other things can cause these symptoms. So balance problems, dizziness, weakness, double vision, bladder or bowel problems, pain, loss of sensation, abnormal sensation, numbness, tingling, pins and needles. All of these symptoms are symptoms that might be occurring. And I've listed some of the commoner ones on this list over here. And that would be the first suspicion of MS, would be the symptoms that someone has, would alert us to the situation. And then we now have this amazing tool called an MRI scan. And probably in the era of most people here, MRI scans have fortunately been around. Actually, in my first year of practice, we did not even have an MRI scan. So why I date myself, I don't know. Because when I speak to my grandchildren, I always, am 40 years younger. But here's the MRI scan, which was an amazing tool that allowed us to diagnose MS because CAT scans don't. And if you look at the scan on top, it says T2 with flare. When you go and see your neurologist and you want to look at your scans, then you tell them you want to see your T2 scan with a flare image. And you'll see those white spots. But this scan, these white spots that you see there on the T2 flare. And then over here you see on the T1, so you ask your neurologist to show you the T1 scan, and you see black holes. Or you give the contrast, which is called gadolinium, and it shows you if lesions are active. Those are the scans we look at. They help us evaluate the MS, diagnose the MS, evaluate the MS, follow the MS, help us understand the results of clinical trials. So MRI scans are a huge advance for MS. And we know we're learning that MS, now we're learning more and more that this is an active disease. It's an ongoing disease. When we said MS is a relapsing and remitting disease, if you spoke of cancer and you said cancer is relapsing and remitting, and someone had a remission, you might say they're free of cancer. But we know when we say MS is relapsing and remitting, they're not necessarily free of MS. There might be no obvious way we know what's going on. We're going to talk about that in a moment. And so there's still evidence that there may be things happening in the brain, but they're having no new symptoms. The scan is stable, yet if we have special techniques, we might be able to see that something is still going on. 80 to 90% of new brain lesions are silent. Someone has a scan, they feel well, and yet the scan shows new lesions. And the opposite can happen. Someone doesn't feel well and the scan is the same. And brain lesions are increasing, so something is still going on. Atrophy increases in patients with MS. All of us experience some atrophy as we age, and in people with MS, atrophy increases, as you see over here, 3 to 10 times greater than controls. And so the goals of all our treatments are going to be to try and slow all these things down. So what this says is that a large proportion of people with MS continue to experience deterioration, despite any obvious inflammatory activity. We look at their scan, we see no inflammation, and yet they're gradually getting worse. Is this what we used to call secondary progressive MS, that they're slowly progressing? So these patients have progression. They have no relapse. On their scan that I've just been through with you, there's no activity. There's no new T2 lesions. There's no active lesions, and yet they're getting worse. Now we have a new name for this that you're going to start hearing about. Maybe for some of you it's the first time you've heard this. It's called PIRA, P-I-R-A, progression independent of relapse activity. And maybe this is what we used to call secondary progressive. But more and more we now are looking and doing research to find drugs. Our drugs that we have now are very effective in slowing down inflammation and reducing relapses. But they're not as effective in stopping disability or progression. So when people have a relapse, they may get worse, and this too we'll discuss in a second. But they may also get worse independent of relapses, PIRA, progression independent of relapses. Whereas if you get worse after a relapse, we call that relapse-associated worsening. You've had a relapse and you're worse after that, that's relapse-associated worsening. You had a relapse and you're worse, you understand that. But then we also have PIRA. So this is two ways that people can get worse, and maybe our treatment approaches to these in time are going to change. What's the importance of a relapse? Can it tell us what the outcomes are? Yes, it can give us information. So here are some things that you think about that tell us about what the long-term outlook of MS is going to be. What's the prognosis? You have 6 factors. The age at onset. Older onset, generally the prognosis is a little worse. The symptoms at onset. So for example, symptoms that affect the spinal cord, like if people have bladder problems, difficulty walking, that is a worse initial symptom, for example, than optic neuritis. What does the MRI tell us? How many lesions are there on the scan? What is the interval between the first and second attack? What is the frequency of the attacks? And how much recovery is there between attacks? So all these things, we put these together and we can say that someone is in a high risk or a low risk group. These are prognostic factors. So when you have a relapse, or you have another relapse, all this information goes and will help us determine what kind of treatment, how active, how aggressive with the treatment. what happens following a relapse. This is studied. If you have a relapse, do you always recover? What does remission mean? Remission just means there's no active disease. But you'll see on this slide over here, this is showing you over here that if people had a relapse, it's showing you what's happening in the first 60 days, 60 to 90 days, and 90 days plus. And this showed you how many people had persistent disability. We have a scale that measures disability. That's up here. It's called the EDSS. Anybody who's been in clinical trials, we know that the EDSS is a very important scale that we use. It's an imperfect scale. It's not a great scale because, as you can see, it predominantly is dependent on walking, ambulation. It doesn't measure other things. Some people with MS are disabled mostly by their cognitive issues, and the scale does not reflect that very well. But you'll see, if you look, I'm going to show you the marker over here, like in this range over here. On the EDSS scale, if someone has a score of 6, that means they are using a cane. So it's an automatic. If we see someone using a cane, they're a 6. If they're using a walker, they're a 6.5. If they're starting to use a wheelchair, they could be a 7. Everything lower down is different abilities of walking. So let's go back over here now and have a look at this one and say that we see that there are people who may have 1 point worse on their EDSS scale. And if they were not using a cane beforehand, it may, all of a sudden, they might use a cane. If they were using a cane, it might progress to a walker. So a small change could make a big difference. This is nothing dramatic. It's what, Stuart asked me to talk about. What's the treatment of relapse? That has not changed. So if I showed this to you 14 years ago, I would have shown you the exact same slide, basically, which is that our treatment of choice for a relapse is still steroid. And typically, the classical type of steroid treatment has been intravenous steroid. We call Solumedrol. We give it over 3 days typically. That is our classical treatment. We could also give you the equivalent amount of steroid by mouth. Now, the steroid that we have to use by mouth is called prednisone. It's a slightly different steroid from what's in Solumedrol. The biggest size tablet that they make is 50 milligrams. The amount of Solumedrol will give you is 1 gram or 1,000 milligrams. That means you've got to take 20 tablets a day, but you can take it at home. So oral steroid could be as effective for you as Solumedrol, but you just have to take a lot of tablets. If you can't get steroid, it doesn't work, we have Acthar, ACTH. ACTH was actually the very first clinical trial that was ever done for MS many years ago, 40 years ago, was done with ACTH. And the reason we don't use it more, it's effective for MS relapse, is because of the expense. So these are things we have to try and work around. And then the final thing about treatment there you see is plasmapheresis. Plasmapheresis is plasma exchange, where we take out your plasma. This is used in very severe situations. And then what else about a relapse? Over here, I'm going to this on the left-hand side there. If you have a relapse, it implies that there's something not working with your medication. So it triggers off on us, what is the implication is, do we need to switch your medication? Do we need to start a new medication? And in that regard, we have to start thinking about what's the sequence of medications? What do we use first? What follows? And finally, if you have a relapse, the final implication, the bottom item here, is symptom management. What are your symptoms? How do we manage them? Is your symptom dizziness? Is your symptom pain? Is it a bladder problem? Maybe we need to re-evaluate the symptom management. So this slide over here is treatment of the relapse and the implications of a relapse, both for your medication, your disease-modifying drug, and for the symptoms. I'm going to leave this up very briefly because this is a whole different discussion, is what drug do you switch to? And these are all archived, so this is going to be on the YouTube archived program, which is that if you have a relapse and we're thinking about switching your drug, these are all the things we have to think about. Sometimes people will say, well, what should we choose? And this is not a 1-second decision, because we have to think about this. What's the safety of the drug? What's the efficacy of it? What are the side effects? Does it interact with other drugs? What's someone's pregnancy considerations? A whole bunch of different things we have to think about. I call these the wheels of decision-making. Never forget about the invisible symptoms of MS. Could these form a relapse too? Someone is fatigued. Someone feels fatigued. And this is from the MS Society, a brochure from the MS Society that said, but you look so good. How many people here look good? Most people, not everybody. No kidding. Everybody looks good. Everybody looks good, but people say, oh, you look so good. Why are you not more active? Why don't you do this? Why don't you do that? You're lazy. How many lazy people are there here? You're not trying hard. You could try harder. You could do more. Yeah. But the invisible symptoms, that's why they're called invisible. So people get, sometimes it can, as it says here, it can affect confidence, it can affect relationships, it can do a whole bunch of things. Very important. And these include things like fatigue and pain and cognitive problems and numbness. There's a lot of invisible symptoms that are very important, and they can be a presenting symptom. Someone can say, I've just got fatigue, and then you're going to investigate it. Is there another cause for your fatigue? Do you have an infection, a bladder infection? Do you have a thyroid problem? There are other things we should consider. And then we rule them all out and we say there's nothing. We can't find anything else. Maybe it's just the MS. Let's deal with that. As we move into the next section that Stuart asked me to talk about, which is pain, when we talk about pain, there's medications that we use for pain. But I put this slide up to show you how many different medications there are potentially to treat MS. We don't have to go individually through this, but there's medications for fatigue and spasticity and pain and the bladder and the bowel and dizziness and a whole bunch of medications that we can treat. And what's the importance of having all these medications? They can interact. We call that polypharmacy. It means that the person could be taking many medications for their MS symptoms, for other diseases. And guess what? All these things interact. So we have to be aware of this all the time. Polypharmacy, interaction between all these. And this is because people have many different diseases. Formularies change, medications change. Sometimes there's poor compliance and poor follow-up. So now that we've introduced ourselves into the symptom aspect, this next topic's symptom that Stuart chose for me to refer to briefly is about pain management in MS. So there was a time in MS where people said, MS doesn't cause pain. Anyone that's had MS for many years will know that. They said, MS doesn't cause pain. If you have pain, you don't have MS. We know, of course, that's not true, because pain can occur quite commonly with MS, and there's many different kinds of pain. And the International Association for the Study of Pain that are quoted there, they said pain is both an emotional and a sensory experience. Again, it's invisible sometimes. People can't recognize it. And someone could have a lot of pain and feel bad, and people may disregard it. So it's an emotional and a sensory experience. And there's two kinds of pain in MS that we're interested in. The first is neuropathic pain, and the second, whatever sequence I have them here, musculoskeletal pain and neuropathic pain. Musculoskeletal means muscle pain, spine pain, joint pain. Yes, MS can directly cause muscle pain, stiffness and spasm of muscles. MS doesn't cause spine pain directly. It is a secondary effect of MS. Because someone has difficulty walking, because someone has a lot of stiffness and spasms, they may get pain in their spine, pain in their joints, like the knees or the shoulders, other joints. These are secondary effects of MS. And then there is neuropathic pain, which is nerve pain. That is directly due to the MS. And I listed over here, I think, did I list the symptoms? Maybe not there in that section, but neuropathic pain is directly the result of the damage to the brain and the spinal cord, and it can cause numbness or tingling or itching or all kinds of sensory symptoms. We also define the pain as described at the bottom. Is it an acute pain? Did it just start? Is it a chronic pain? Has it been there for a long time? Is it there every day? These are questions we want to know. Or is it a paroxysmal pain? What does that mean? That means it comes and it goes. The classic example of that is trigeminal neuralgia, which I'm sure a good number of people have experienced. It's a common type of pain for MS. So here we're looking at musculoskeletal pain, muscle stiffness, spasticity, muscle spasms, and secondary pains. Because you've got MS, you get joint pain, you get back pain, you get neck pain, you get headaches. Those are all musculoskeletal. And pretty much we treat them the same way as we treat musculoskeletal pain for any other cause. Here's neuropathic pain. Okay, here I've listed some of the components. Burning, tingling, itching sensations, cold sensations, etc. It can be intermittent, it can be constant, it can be paroxysmal. There could be sensitivity to touch. And nerve pain is often worst at night. Trigeminal neuralgia is a very specific, common type of pain. Now, trigeminal neuralgia can occur in people that don't have MS, typically occurs in older population, but it can occur in people with MS too. And when it occurs in people with MS, It doesn't respond as well as in people that get it without MS, but it's a very sharp facial pain that can come and go, and we have medical treatments or surgical treatments, and then there can also be other type of neuralgias, other type of sharp nerve pains in different parts of the body. Another example of an MS pain that I'm sure some have experienced is the MS hug. MS hug is another type of neuropathic or nerve pain of MS. This is how we evaluate pain. When you think of pain, and these are questions we ask you if you have pain, you'll see there's an acronym. This comes from the MSAA, MS Association of America, have this acronym, which is old cart. What are we going to ask you about your pain? Tell us about how it began, the location, the duration, the character of the pain, what aggravates it, what relieves it, what treatments have you tried, old cart. These are questions we want to know about the pain that help us evaluate maybe what's causing it and to try and decide how to treat it. Treatment of pain. Now we're going to talk about treatment of neuropathic pain, treatments, and we have two types of medications essentially that are commonly and routinely prescribed, and that is anti-seizure medications. That's gabapentin, which has been around a long time, and Lyrica, carbamazepine or Tegretol, and oxcarbazepine. These are some of our standard anti-seizure medications that we've used for a long time, and they do help quite well, actually, these medications. And generally, they're well tolerated. They have side effects. Some people can tolerate high doses. Some people have side effects with low doses. Again, goes back to this individualized or personalized aspect of treatment. And then we have antidepressant medications. I've listed some here that will be amitriptyline, nortriptyline, or Cymbalta or duloxetine. Amitriptyline's been around for a long time. It's an old antidepressant, and it's still effective for helping pain. It's still effective. But these medications have side effects. They may cause drowsiness, constipation, dry eyes, dry membranes. Some of the concerns about some medications over here are that they can affect memory. And some studies have shown that if people take some of these antidepressants for a long time, it can affect their memory. It can have long-term effects on memory. So again, we have to balance everything up. We're always looking for these medications at the risks and the benefits. Always looking at that. And then there are what we call cannabinoids, the various formulations of cannabis that do help people with MS with two symptoms. The one is pain and the other one is spasticity. So in the field of pain, cannabinoids have been a useful addition, but they're, of course, very closely regulated. And then there's a variety of other things that we talk about with pain that we look at on this page. And this is musculoskeletal pain. We might try this for neuropathic pain too. For example, exercise, physical therapy, massage therapy, acupuncture, biofeedback, all these things that we've used for musculoskeletal pain, we might try some of these for neuropathic pain too. Tylenol, non-steroidal drugs, again, we never want to use a non-steroidal drug for a prolonged period of time because of cardiovascular and kidney side effects. Antidepressants, antispasticity drugs like baclofen or tizanidine. Botox is helpful for muscle stiffness and muscle spasticity. Cannabinoids help pain, help spasticity. Opioids is a last resort. So that would be when we've tried every other method to try and help someone and they still have severe pain that is affecting the quality of their life. Then we might refer them for pain management and consider the use of opioids. That is the end of the section on pain. So that came from the symptom tower on the right-hand side there. We were in the symptom tower. We could have picked any symptom today, and you'll hear about other symptoms as the day goes on. But the one that Stuart picked for me to tell you about was pain. And then when we move down on the right-hand side, we look at measuring, how you measure MS. And we've talked about some clinical features, the importance of individualized evaluations, the MRI scans, and then included in that slide you saw was biomarkers. So this is a new area of MS. We've been looking for this for a long time with MS, as to do we have some way we can measure MS? And that's called a biomarker. And this is a biological substance. And it can be found in blood or other body fluids or tissues. And it can be a sign of a normal process, normal function, or an abnormal process, or a sign of a condition or of a disease. And here is a description of it. It is a characteristic that is measured, objectively measured and evaluated to indicate a biological process, either a normal biological process or a pathological biological process or a response to a treatment. So this is what we're trying to develop, markers that will actually tell us what's happening. Because we said before that some of our measures, clinical and MRI, we spoke about those, and we said they don't always tell us the true picture. There could be smoldering MS, yet when we examine you, the examination doesn't change. And your MRI scan hasn't changed, but you're getting worse. Smoldering MS, progression without a relapse. And so are there better ways for us to measure this? So potentially, in the future, we're hoping these biological markers are going to help us measure this. Can anybody see that beside me? Okay, so this is archived, but that's why I put it here, so you've got the information. And essentially what this says is that we now have this biological test for biomarkers, and it's called Octave. Octave is the company that developed this, and I'm going to tell you a little bit about it, so don't look at the slide. But it's there, it's going to be there for you. So this company developed biomarkers. They looked in the blood of people with MS, and they found over 1,000 markers, tiny proteins in the blood that are reflecting someone's MS activity or how much inflammation there is arising from their brain and their spinal cord. Those are biomarkers. They evaluated over 1,000 of them. And they came out of the 1,000, they developed a panel of 18 of them. This describes some of them on this slide that you'll be able to see on the internet, if you like. That's why I put these in, really. They're for information. It was hard for me to put these into a larger format. I don't know how to make this larger. But on the right-hand side, you'll see that they have the 18 proteins listed. So this is called the Octave MS Disease Activity Test. We're still learning how to use it. We're learning. Very often it might correlate with the way someone is feeling, and sometimes it might not. And we're trying to learn still, as the numbers of people using this increase and the numbers of patients that we have that have had this, we're going to learn more and more about different groups of patients what to anticipate with this test. I think this is going to become very important. This is what we've been striving for in the past. So there's 18 markers that you see on the right-hand side. And on the previous slide over here that you can look at on the internet, I gave you an example of what 3 of them do. The one is called neurofilament light chain. And the neurofilament is actually a part of the axon. So the axon is the actual nerve fiber. And when it's inflamed or diseased, the tiny little pieces of protein, nanoparticles, tiny pieces, maybe that we need very special technology to measure, we might be able to detect them in the blood. And then the next one that I gave you an example is from the astrocyte. The astrocyte is another cell in the brain. These are from different cells. And the final one that I gave you an example is called MOG. And this is related to myelin formation. There's a cell in your brain called an oligodendrocyte. And these are all different parts of the nervous system. That's why I listed these 3 that you can look up. And when they break down, then you see different proteins. And we're trying to learn what the pattern of all of these is. And then you get a printout like this. So every time we do your test, this is the result that comes, and we go over it. And you'll see on the right-hand side, there are 18 proteins that are listed, and it's going to give us a breakdown of how much you have of them. On the left-hand side, you'll see overlap between 4 categories that they've worked out, related to the immune system, related to the immune system, to how much inflammation there is, to breakdown of the axon. So these are different components that we're going to look at, and they have an algorithm to work out what your score is going to be. So for example, this is not a real patient, by the way. Whoever they showed that name is a fake name. And this is an example of a score that shows you a score of 5. So this is a test that gives you a score out of 10. And this score over here on this person is a 5. Anything up to 4 we consider low. 4 and below is low. That would imply whatever treatment you're doing seems to be satisfactory. When you go from a 4.5 to 7, that's moderate. That means we're on alert. Your treatment probably okay, but be on alert. Depending where you are, if you're closer to 7, maybe we'll think of making changes. And anything over like a 7.5, we need to make some changes. Something is not right. So this is our understanding. Now, mostly this test we understand very well for relapsing types of MS. When the MS is earlier or when the MS is more active and a lot of inflammation, we understand this very well. For progressive or smoldering types of MS, we're still under evaluation as to how to use this better. And so the more information that we can send and gather, the better this is going to be. Let me go to the next one. I just wanted to show you this slide, and this probably applies to every drug. This was from a drug trial with a particular drug. This one, I think you can see the numbers. Can you see the numbers on this one at least? Yeah, hopefully. So if you look over here, you're going to see over here that this is the scores, like I told you, low, moderate, and high. And you can see at the beginning of the study over here, you can see that 16 out of these 21 patients had a moderate or high score. And in week 96, almost 2 years later, 0 patients had a moderate or high score. So that's for this particular drug, and hopefully this will happen with all drugs. What I'm showing you over here is just potentially how the test could be used, how at the beginning over here, 16 out of 21 patients had a moderate or high score, and almost 2 years later, they were down to 0. So in this regard, the test helped us a lot. It's much easier for us to do blood tests to monitor progress than it would be to do frequent MRI scans. Certainly much easier to do that. So this is an example of how in a study this helped us. Here's an example. This is a real life example. This is a person that is very stable, no new symptoms, MRI scan stable. We did the test on her and it came back with a score of 2.5 or 2.5. That's her score over there. Now, as we do this over time, we'll start to plot these scores out and see how it is over time. Look at this one. This is a person that had a relapse, and associated with the relapse, there were multiple active lesions on the scan, half a dozen lesions on the scan, very active disease, and this person has a score of 9. Very active. So, I mean, even without this test, we knew from her symptoms in her scan already, we need to change the treatment. We knew that already. But what this affords me now, what's going to be really interesting is that we've changed the treatment. I'm going to repeat this maybe in 3 months. And in 3 months, if I see a score of 6, a score coming down, it'll be a very good way for me to monitor this, because they might feel better, the scan might be better, but there may still be things happening. So this is telling me some more detail. So that's the way I think going forward, I think the biomarkers have been a huge advance, and hopefully we'll learn more and be able to understand it and use it much more. This is my final slide, and just tells you where we've come with MS. That in 1868, you'll see that Charcot, a very famous French neurologist, described MS. Think about that. It's over 150 years ago. And then the first time MS was described in the United States was about 20 years after that. In the late 1880s, MS patients were recognized in the US. And then in the early 1900s and later, they started to understand about the changes in the pathology of the brain. But only in the 1960s, almost 100 years after Charcot diagnosed MS, that we first realized this is some kind of immune disease. And then in early 1980s, we had the MRI scan, which was a huge advance in evaluating MS, showing you the progress. The first drug approved for MS, beta-seron, 1993. That's all, 30 years ago. And now over 20 approved drugs for MS. And now I could add at the bottom of the slide, biomarkers. So constantly we're evolving. There are many drugs still in clinical trials. We're moving forward. We're fighting the battle. So that's all I have to say. So thank you for listening. And
thank you very much.
Hi, Dr. Steingo. How do you get a biomarker test done?
How do you get it? Your neurologist, it's available. It's commercially available now. So you could ask your neurologist to prescribe it for you. In our office, we actually are set up to draw the blood, and then the blood gets sent away to the lab, to the Octave lab. But you can do it. There are other labs that the company Octave has contracted with. This is not Quest or LabCorp. This is some private, smaller labs that this company is contracted with, and you just have to have your neurologist give you a prescription, and you can get it done.
Is it covered by the insurance?
I would say almost all. If you have Medicare, I think it's always covered. And if you have other insurances, it's mostly covered. I think I would say for the great part, it's covered. And if it's not covered, they have some kind of financial guarantee as to a maximum cost. So it's not like it's going to be, for the most part, I'd say we have not had any problems at all.
Dr. Steingo, can you please tell them the cost of getting this scan? Do you know the cost?
The cost?
Yep.
So so if someone has Medicare, as far as I know, it's covered. With most insurances, it's covered too. And the maximum, and then what they have is they have a pay scale as to what someone's income is, and that will be the maximum cost. But the maximum cost for anybody is $149. So even if you don't have insurance, or you have insurance but it doesn't cover it, or something weird, the maximum cost that they guarantee is no more than $149.
Great, thank you. So before I go to Jennifer, a person from Austria that's online right now, Austria, all right, is asking, are biomarker tests available in Europe, specifically in Austria?
Patricia? Where's Patricia? Is Patricia here? It's Patricia.
Okay, you're going to have to repeat that, Dr. Steingo, because she doesn't have a mic. There you go.
Sorry, not in Europe yet.
Okay, thank you. Well, there's the answer, the person in Austria. It's not in Europe yet.
Yeah, is there any new treatments for double vision that's associated with MS?
And there's no new treatment. So when you have a symptom, as we spoke about before, there's two things to address. The first thing is if you have the symptom and you have a particular medication, it implies the medication is not doing its job because there's a new symptom. So that leads us to discuss whether we need to switch the MS medication. That's number one. Number two is if the symptom is double vision, we need to treat the symptom itself. In general, if someone has double vision, we're going to refer them to a neuro-ophthalmologist. There's no specific drug for it. They're going to generally will find the cause and give someone prisms. Number three, of course, is depending on the age of the person. Double vision has other causes. For example, in our older MS patients, commonly double vision could be a sign of a stroke. Double vision is common in diabetics when they develop nerve palsies. So we have to always make sure also that there's no other cause.
What can be done if a neurologist does not do anything but collect conditions only once a year? Meaning if the person, I guess they're saying that they might be having a lot of problems during the course of the year, but his or her doctor will only see them once per year.
Recently, I saw a patient whose cholesterol was about 240 and their LDL was about 170. This is a disaster for the future, for strokes and heart attack or whatever. And I stressed to them, I said, what are you doing for this serious position of your cholesterol and your lipids are completely out of, what are you doing about it? I said, my doctor said I should change my diet. I said, I have a better suggestion. Change your doctor. I mean, that's ridiculous. So it's the same thing. If someone needs to be seen more often, they need to find, we talked about that before over here. Remember in the land of MS, the control tower, well, I come up here now. And there's a lot of symptoms to review. So the answer to that is if that person's not satisfied to, see someone else.
Yes, so your presentation, doctor, was primarily targeted to individuals with relapsing MS. The same facts that you presented here for relapsing come into effect for primary progressive.
No, of the drugs, we mentioned that there's over 20 drugs, if you count all the generics and everything, for MS now. And these drugs are all approved for the relapsing types of MS, of which there are several, but only one of them, which is ocrelizumab, is approved for primary progressive MS. And we're learning more about primary progressive MS. So primary progressive MS is still way behind in what we can do for it. We're learning more about it. We're learning, I put some of those terms up there that you're going to start to become more familiar with. Smoldering MS, a progression without relapses. So over time, we're going to learn more about these types of MS. But for primary progressive MS right now, we only have one approved drug. Even the biomarker test that I spoke to you about, we're not exactly sure how to interpret that in primary progressive MS yet. But when we have large numbers of people, we'll know more about what to do for that. But that we're still, I would say we're still way behind what we can do for relapsing MS with primary progressive.
General question, if you have new symptoms on a
So the general question is that
drug.
a person a person over there was on Gilenya, and they were switched to Mayzent, and they feel worse. So Gilenya is an older medication. It was approved in 2010, and it's a category of drugs called S1P drugs. Mayzent is in the same family exactly. It's an S1P drug. It is a newer drug in the same family. These days, I think most neurologists prefer Mayzent. It has some advantages. For example, maybe a quicker recovery. Mayzent also was shown to have some benefit actually for secondary progressive MS in some of the trial studies. The biggest reason, though, for a switch came about when Gilenya became generic. So Gilenya switched to a generic. So at that stage, we had options. Option number one is stay with the generic Gilenya. That is an option that someone could do. Of course, if you were getting support, if someone was getting support for their Gilenya, they wouldn't get the support anymore, but maybe the generic would be affordable. Or we could switch to a drug that's very similar that they might get support. That's how Mayzent came about. The drugs work identically. Their mechanism of action in MS is identical. There's nothing different about the way they work. It's not like you're going from Gilenya to a completely different drug. The way they work is identical. So if you are feeling worse, it needs to be evaluated. You should be evaluated like we would evaluate anybody else who's feeling worse. Are you progressing independent of relapses? Are you having relapses? You need MRI scans. Potentially this test that I spoke about, the biomarker test, would be interesting. That's what I would do. Your symptoms require evaluation. I would be very surprised if there would be a change just based on the switch, because the drugs work on an identical pathway. But it's possible. I can tell you that in patients that have switched, it has been reported that people even stable on Gilenya have occasionally had a relapse. So it's possible that the drug is different, slightly different, although they work the same way, but it needs to be evaluated. That's the key thing. It needs an evaluation.
Thank you. We have approximately another 15 minutes of questions. I have to take one from the internet right now, and the person's asking: are there any treatments for secondary progressive MS or smoldering MS?
So secondary progressive MS, that term has been around for a long time. This was somebody, as we said before, the commonest way that MS starts is by relapses. 80 to 90% of people start out with a relapse, which has many different names: an attack, an event, an episode, an exacerbation, many names, and they start with an attack. And then they're quiet for a while. That means they're not having an attack. They're stable. Doesn't mean that there's nothing happening in the brain, because now we're learning that there may be things happening in the brain that we call smoldering. But the typical MS attack or relapse is the way we've always known MS. And we have all these drugs now that are approved for treating relapsing MS. And why are they approved? Because they reduce relapses. That's what they do. They reduce relapses. But they're not as effective for slowing down the disability. They might slow it down a little bit, but not as effective as for the relapses. So there are things that are happening in MS that we're starting to learn about, and one of those is what we call smoldering MS, that there are things happening in the brain that we haven't been able to measure very well so far, and we're needing and utilizing and developing special techniques to measure those. And again, potentially, the biomarker test might be something that tells us about that there's breakdown products of nerve cells that show that there's some smoldering activity. If we just said the word smoldering activity, that might equate to secondary progressive. If someone is secondary progressive, we've now split that into two categories. The first category is active secondary progressive. What does that mean? That means that someone is slowly progressing, but they still might have evidence of activity. That could be that they have a relapse. So let's say I saw someone a year ago. Now a year later, they're in, and they're a little worse. Their walking is worse, but they had no relapse that they know of. We do the scan is the same. That would be secondary progressive. They've progressed. Now let's say they come in a year later and we do a scan and there's some active lesions. Now we have signs that there's inflammation. So we might label that active secondary progressive. Are they really different? I don't know. Right now we have those terms. I suspect over time they might be more close than different. But we treat them a little differently because the medications that are approved are when there's a relapsing form of MS. We want some evidence of activity. But really you could look and say if someone's worse, something's happened during the year. We just missed when that event happened, but something happened during the year. So the more we know, the more we know that we don't know, like with everything. So if you said someone just has smoldering MS and there is no activity at all, theoretically, if we called it progressive, our options are very limited.
Thank you very much. Question over here.
Yes. Hello, doctor. Thank you for being here. I heard that brain shrinking or atrophy is a sign that the DMT is no longer working for that patient. Is this true or?
So as I pointed out in one of the slides, people with MS experience this as part of the course of the disease, is that the atrophy, the rate of increase in atrophy in MS patients is increased. And we've known this always. Even in people on treatment, we've known that there's increased rate of atrophy. But all the new clinical trials that are being done now, we start to measure that and to see if the drug can reduce the rate of progression of atrophy. So this has become one of our endpoints. So when we look at a clinical trial, we look to see, does the drug reduce relapses? Does it slow down the progression of disability? Besides, of course, looking at side effects, etc. But our measurements are, does the drug reduce the risk of relapses? Does it slow the progression of disability? And potentially we might also look at, does it reduce the progression of atrophy? So we would look at a drug. In our trials nowadays, when we do a trial, we usually compare a drug to another drug. And we say, on the drug that we're trying, is there less progression of atrophy than on the drug without? So theoretically, if someone had more atrophy, increasing atrophy, it might suggest the medication is not working. Again, it's like an invisible thing. It's how do you measure that? And it's not easy to measure atrophy. You need specialized MRI scans that can actively measure that. And there are those scans. Mostly they're used in clinical trials. But other than that, when we do a routine scan in practice, we're really eyeballing it. Sometimes that's why it's useful to use the same scanner, because you can eyeball the scan. And there are technologies and companies, including the same company we spoke about, that are doing the biomarkers, that are looking at scans to try and make measurement of atrophy a mainstream thing. So that actually we can do a scan and tell you what the volume of the brain is and measure that over time and say, well, the brain volume is shrinking more than we expect. Maybe it's time to switch to medication, and then look at the medications and say which medications are more effective in slowing down the progression of atrophy.
As a result of what you just said about smoldering MS, would you change the treatment if the person does not have activity, or with activity? Would you change the treatment with the resources that we have so far to evaluate the progression of that MS? And the other question is, many of the MS patients has other diseases that the symptoms are very similar to MS, like for example migraine and MS, right? So when we know that how to differentiate that those symptoms are related to MS or is a plain migraine. And for example, for symptoms like that are more sensory, if you have a sensory symptom like a little bit of more numbness or tingling on your legs that you see that it's remaining for a while, but you do not have a change the movement, you have an intact range of motion. What would you do to evaluate if this person needs to change treatment or not?
I'm going to summarize the answer to both of them. And so the first question is, really, if someone has MS and they're feeling worse, and they're either progressing independent of relapse activity, or they're slowing, or they're secondary progressive, then theoretically, if you stick by the books of what MS drugs are approved by the FDA, we have no actual drug that's approved for that. But we have what we use off-label. So this would be a discussion between someone and their neurologist about saying, this drug is not slowing down my disease. Is there something else we should consider? And it'd be a very personal decision you would look at with your neurologist to switch the drug. So that would be my answer to your first question. As regards the second question, this applies very well to when we diagnose MS early on, that there are many things that mimic MS. For example, aging can cause white spots on the brain, or migraine, or Lyme disease, or sarcoidosis, or lupus. There's many other diseases that cause white spots on the brain that can mimic MS. And similarly, some of these diseases could cause similar symptoms. For example, a diabetic patient could have numbness of their feet. What's causing their numbness? But at the end of the day, we treat numbness the same way. It's just if they're having more numbness, then we would do other tests to see if it could be reflective of MS activity, which would mean maybe we need to change their drug. So I think that's a...
Should the neurologist have each person, say annually, do a biomarker test so that they can have like a benchmark?
The answer is, we're learning about the biomarkers. And our hope is that the test now, is new. It's only been around for, within the last year, especially as more and more neurologists use this and we accumulate large numbers of people, we'll be able to understand the significance of the test. And for example, in my practice, I've started incorporating it as necessary, and I'm seeing differences in different patients. I showed you 2 examples of the patient with very mild activity and doing stable, and the person that had very active scan. So I think the more information that we can gather, the more we can learn about the test, and then maybe the answer to your question will be yes. If the test is a test that tells us how someone is doing, the amount of damage, the amount of inflammation, etc., it may become something that we do routinely to measure, just like you measure blood sugar in a diabetic or blood pressure in a hypertensive patient. Maybe this is our marker that. This is a question for the future, but right now I'd say I'm hopeful that will happen.
All right, last question. It's coming from the internet. People want to know, more than one asked, if they are over 60 and they have been very stable with their disease course for more than 10 years, but their neurologist is saying, hey, it's time that maybe you get off of their medication. What are you telling them?
I mean, there's a lot of studies that have been done for this. There's discontinuation of MS therapy in older MS patients. I mentioned to you before that the average age of an MS patient in the United States now is 55. So we look around the room and we say, yeah, we can see that. So the average age of an MS patient is 55. Although the disease typically starts between the age of 20 to 40, most commonly, the average age of an MS patient is 55. And some people have proposed that when people are older, the disease might actually burn out. So if you've got an older MS patient who's stable, what does that mean? They've got no new symptoms. Their exam is stable, their MRI scan is stable, maybe for 5 to 10 years. Maybe they can stop their medication. And so studies have been undertaken to do this. The biggest study in the US was in Colorado, and really it's inconclusive. They could not show you that if you stopped, you did any different for whether you stopped or continued. So it's kind of inconclusive, and I think the study will continue. I would say it's inconclusive. Let me tell you that some other studies have been done that have shown more recently a study from Europe that when people discontinue their medication, about 20% of patients had worsening. 20%. That's not a low number. If there's a 2%, maybe you can think of stopping. So right now, I've become more inclined to say to someone to continue the medication. Also, the medication that someone's on is important. So, and this is what I'm about to say, it makes sense, that if people are on milder drugs, like glatiramer acetate or Copaxone, as compared to someone on a more powerful drug, the people on the milder drug tended to do better than the people that came off. So people that came off stronger medications tended to have a greater chance of progression. We know that there are some drugs that if you come off the drug, for example, the S1P drugs like Gilenya or Mayzent, those drugs in that family, or if you're on a drug like Tysabri and you stop those drugs, there is a high risk of a rebound, relapse. Or if you stop some other drugs like Copaxone or dimethyl fumarate, the risk of a relapse definitely is less. So in answer, that's the answer. It has to be individualized, but also would depend on your drug and the symptoms that you have as well.
Thank you very much, Dr. Steingo. Don't run away. I got something for you. And we have a certificate for Dr. Steingo. Thank you very much. Everybody, thank you very much for coming, and thank you all for being online. Bye-bye.